Hello, everyone. Tonight on Get Fit, Stay Fit, Never Too Late video podcast, we're joined by one of the top ophthalmologists in the United States of America and one of the top doctors in the state of Connecticut, Dr. Alan Solinsky. And why do we get cataracts?
Basically birthdays. We get older and we get them. Also UV light exposure, people that are outdoors all the time without good sun protection with a hat or UV protection glasses.
And so what are the surgical options for patients with cataracts?
Yeah, well, surgical options, there's a wide range of surgical options. First is the basic cataract surgery, where you take the cataract out and you put a lens implant in, and the patient will certainly see better, but they're most likely going to need glasses for far away and up close. Then there's what I like to call the custom cataract surgeries, where the patient does pay extra, but they will get different measurements done in the office. In addition, I'll tell you one more breakthrough. It's called the light adjustable lens. That is the most accurate lens on the planet. That is the most accurate one because we do the cataract surgery with all the details that I just mentioned, plus we put the lens in the eye and then we let the eye heal for 1 month.
The goal of the podcast is to provide a platform where members of the medical community and the healthcare community in general can interact with the general public in an environment that is outside of the doctor's office and the hospital. Our podcasts will focus on what are the preventive measures that the general public can take in order to give themselves an opportunity to live a longer, healthier, and the best quality of life that is possible. We will also focus on informing the general public on how to identify warning signs and what to do when we recognize the warning signs. Early determination of illnesses provides the best opportunity for recovery and may require less costly medical procedures. A healthier public is in the best interest of everyone. People will live longer and better quality of life. The pocketbooks of the patients and the medical insurance providers should also see a reduction in expenditures. Healthier people generally require less costly medical procedures. Get fit, stay fit, never too late. God bless.
Hello, everyone. Welcome to Get Fit, Stay Fit, Never Too Late. This video podcast is here to help us all stay in good health. Tonight, we have a very special guest that has taken the time out of his busy schedule to join us. Our special guest is a graduate of the University of Connecticut School of Medicine. He trained at Hartford Hospital, Henneman University, and St. Christopher's Hospital for Children. He's a clinical instructor for the Department of Surgery at University of Connecticut. He is a board-certified ophthalmologist and is a member and diplomat of the American Academy of Ophthalmology and the National Board of Medical Examiners. He has performed thousands of eye surgery, and has been in practice since 1990. And that's right, I said thousands of microsurgical eye operations, and has been in practice since 1990. He was selected one of America's top ophthalmologists by the Consumer Research Council of America, and also one of Connecticut's top doctors by Connecticut Magazine. He also is the owner and operator of Solinsky Eye Care. Solinsky Eye Care has 11 locations in central Connecticut and is comprised of 5 of the best ophthalmologists and 11 of the best optometrists to help ensure that patients are receiving the best eye care in Connecticut. So welcome, Dr. Solinsky. Thank you for taking the time out of your busy schedule.
Thank you so much, Paul, for that beautiful introduction. I'm very humbled by it.
Oh, well, you did it. You did it. I'm just repeating what you did. So thank you for taking the time. So we'll get started. Why don't you tell us a little bit about Solinsky Eye Care?
Well, like you said, it started in 1992, actually. First 2 years, I did a little something else. But 1992, going back 33 years, I had one small office on Farmington Avenue in West Hartford, one employee, and now we've blossomed into 11 satellite offices. West Hartford's our main branch. And like you said, we have a lot of doctors and we have 150 staff, and we service Probably about 70 or 80,000 patients every single year. And between myself and my partners, we do about 3,000, probably 3,500 cataract operations a year.
Wow. Wow. That's so to say the least, you're quite busy.
We are.
Well, we have a lot to get to tonight, so I'm going to jump right into it. We want to make sure we get as much knowledge as we can from you so our audience can figure out how to keep their eye care in the best possible shape as possible. So why don't we just start with you telling us a little bit about standard eye exams and what are some of the tests like acuity tests? What's a visual acuity test?
Well, visual acuity is a typical 20/20, which says that you're able to see the chart at a distance of 20 feet, like a normal person could. If you can't see it at the 20 feet, your vision might be 20/40, which means that the normal eye could see at 40 feet, which your eye can only see at 20 feet. So someone could see twice as well as you. So you'll need glasses to correct that.
I see. And the color blindness test?
Yeah, color blindness test we do. Mostly males have it. A minority of males hardly ever see it in females. Occasionally, someone with good color vision has a pathology in their optic nerve, so their good color vision could change to bad color vision, and that's a sign that something might be wrong. But just having color blindness at birth, that's just a genetic thing, and people get used to it.
Gotcha. Gotcha. And a cover test?
Yeah, cover test is mostly to test, cover one eye at a time to make sure you don't have a lazy eye. Make sure one eye's not drifting in or drifting out. That's mostly done in children or in adults when they have a diabetic or hypertensive a nerve problem.
I
It
see.
could indicate that, and it can indicate something even worse. Sometimes an aneurysm to the head could
Mhm.
make an eye deviate one way or another. So cover uncover test will help you with that.
Interesting. That's very interesting. That's really good to know. And refraction?
Refraction is what's better, number one or number two? You're behind that dial, and the doctor's turning the dials and asking you which is better, number one or number two. And it checks your sphere for far away or up close. It checks your cylinder for distortion. And usually you have an auto refractor first so that the doctor can get close to where you're going to be.
Gotcha. And you mentioned it, autorefractors and aberrometers. What are those?
Yeah, well, the auto refraction is an automatic refraction done by a machine, and it gets pretty close to where you're going to be. It's refined by the doctor. An aberrometer tests for high order aberrations of the eye. If a person has a cornea that's not in great shape, like a keratoconus, for instance, where
Mhm.
the cornea is cone like shaped, or previous injury, or a bad cataract, they can have aberrations, which means the image getting into the eye is just distorted quite a bit, doesn't get into the eye very well.
I see. And we'll get into it. I wanted to ask you what would that lead to, but I think we're gonna get to that in a little bit. So I'm gonna hold back on that question. And the final test I'll ask you to elaborate on is the slit lamp examination.
Oh, well, the slit lamp, that's you're basically looking at the front of the eye at the cornea, and it's got a slit on it, a slit beam, so that you could get some depth perception looking at the cornea, because the cornea is only a half a millimeter thick, actually. And you want all the depth perception you can get on that. And you also can aim it at the back of the eye as well. And the slit lamp exam's done on any exam to look at the front of the eye. It's also used to help you focus during laser procedures.
Gotcha. And now, typically, on a typical exam, do you normally do all of these tests or just some of them? What on a typical exam, just to close this segment on eye exams?
Yeah, I'd say on a routine exam, someone coming in for an eye exam for glasses, you'll do all those things except the aberrometer.
Hmm.
Yeah.
Okay. So let's move on to cataracts. Now, what are cataracts exactly?
Yeah, well, let's start with what's the lens of the eye. The lens of the eye is right behind the iris and it focuses, kind of like the lens in a camera.
Hmm.
As it gets cloudier, we change the name clear lens to a cataract. So it's the same lens, but it's cloudy, and we call it a cataract. And the cataract symptoms will be decreased vision, glare and halos, especially when you drive at night. Things are dimmer as well.
Gotcha, gotcha. So, and those are some of the indications that we do have a cataract for what you just mentioned.
Right. The patient will come in with those signs and symptoms, or the doctor might ask them if they're having those problems.
Gotcha. And why do we get cataracts?
Basically, birthdays. We get older and we get them. Also, UV light exposure. People that are outdoors all the time without good sun protection with a hat or UV protection glasses, they'll get them sooner in life. Uh, People who have diabetes will get them earlier in life, as well as people who use steroids get them earlier in life as well.
Oh,
But
I
everyone will get them.
okay.
You know.
It's just a matter of time and when.
Right. Yeah, it's a threshold of when the patient wants it done, when it affects their activities of daily living. And also, the doctor has the legal responsibility to tell a patient if their vision's uh, worse than 20/40, they need to either get their cataracts done or they need to turn in their license because you have to see 20/40 or better to drive in Connecticut.
Oh, I see. I see. So, from what we've just learned, we can't prevent them. It's just a matter of time. So, what can we do to make that matter of time later than sooner?
Yeah, it's basically wear UV, just like you'd protect your skin. You're going to wear a hat, broad brimmed hat, a cap, and sunglasses.
Oh, I see. And so, what are the surgical options for patients with cataracts?
Yeah, well, surgical options, there's a wide range of surgical options. First is the basic cataract surgery, where you take the cataract out and you put a lens implant in, and the patient will certainly see better, but they're most likely going to need glasses for far away and up close. Then
Mhm.
there's what I like to call the custom cataract surgeries, where the patient does pay extra, but they will get different measurements done in the office, and they'll get different lens implants at the time of surgery, such as an autofocus lens or a multifocal lens. They will also get an astigmatism lens, which is called a toric lens, and a lot of this is done with laser assisted cataract surgery for greater accuracy. And we use an aberrometer, which we were talking about before. It's called the Aura Verify machine to verify the lens implant after it goes in. So there's a lot more work by the doctor preoperatively and during the operation to get to the patient to the finish line, which is to decrease the need for glasses.
Right.
In addition, I'll tell you one more breakthrough. It's called the light adjustable lens. That is the most accurate lens on the planet. That is the most accurate one because we do the cataract surgery with all the details that I just mentioned. Plus, we put the lens in the eye and then we let the eye heal for 1 month. After 1 month, the patient comes into the office up to 5 times, and we could adjust that lens with gentle UV light therapy, which will sculpt the lens exactly the way it needs to be. So instead of
Mhm.
needing to make up the difference in glasses in front of the eye, you're actually sculpting the new lens implant with UV light to correct the astigmatism or correct the sphere forward or backwards, or make it a little bit better for far away or up close.
Interesting. So, in layman's terms, you're actually putting a new lens into the patient's eye to start.
Yeah, in every single case, you're always putting a new lens, whether it's the basic, you wear glasses afterwards, it's the custom lens implants to decrease your need for glasses, or it's the light adjustable lens. But yeah, everybody gets a lens.
Okay. And now we have this newer technology that you don't have to wear glasses. You can actually adjust the lenses internally to improve the patient's vision.
Right. Although I will correct one word you say. We can never say you're never going to wear glasses. We
Gotcha.
could say we'll
Gotcha.
decrease your need for glasses. I would say with the light adjustable lens, we decrease it by at least 95% of the time. You should be able to see everything you want to see. Maybe you'll put them on for driving at night in unfamiliar places or reading really, really fine print. And those other autofocused lenses will be about 80 to 85% of the time, no glasses. And
Interesting,
some
but
people, some people are lucky; it's 100%, but we can't guarantee that.
sure, understood, understood. How new is this technology? How long has it been around? Has it been around?
Well, lens implants have been around since the 1970s. What's called phaco emulsification, which is small incision cataract surgery, has been around since the 60s, but I would say it's been pretty much used in the way it's used now in the 1990s. Small
Mhm.
incision cataract surgery means making the incision through a 2.4 millimeter incision. In the past, you had to open up the eye halfway to 11 millimeters and even sleep with sandbags on in the hospital. So it's been a
Mm,
long time since like the 1950s and early 60s since we've had to do that. Um, so big progress in the way the cataract comes out. And then laser assisted cataract surgery started in 2008, and we brought it to Hartford Hospital in 2012. So that's 13 years we've been doing femtosecond laser assisted cataract surgery. The high tech lens implants with toricity and multifocality, those have been used for about, I'd say, about 20 years, 15 to 20. Yeah, about 20 years now.
I see, I see. So
And
my
and
question
the
is,
light adjustable lens been available since about 2017 in the United States.
okay, so that's fairly recent in medical
Yes,
terms. Yes.
correct.
Now, once this surgery is done successfully, I know each patient differs, we know that. But how long do you think that the patient should be able to go before the process starts to reinvent itself, where they may need another laser surgery to put a new lens in? Or is it a lifetime thing, once it one and done? Or is it 10 years, 20 years? How does that work? Or does it just vary?
Well, somewhere in between what you said, you should never need a new lens implant put in. These are plastic lenses; they're going to last a lifetime. Okay,
Gotcha.
so that should never have to happen unless there's trauma or something else to the eye afterwards. However, when we do the cataract surgery, we leave the back surface of the original cataract in place, called the capsule. We leave that there to hold the new lens implant in place. That has little epithelial cells,
Uh-huh.
and that always gets cloudy to some extent. And I'd say about 33 to 50% of the time, we bring the patient back to the office to do a very simple laser procedure to make an opening in that cloudiness. And that's used with a slit beam, like we said, attached to a laser. And that's a process that takes 3 to 5 minutes.
Got it. Got it. Okay, so let's move on to the next topic that I'm just going to read a quote here. Is known as the sneaky theft of sight for lack of symptoms. And glaucoma is the second leading cause of blindness in the world, according to the World Health Organization. So, why don't you tell the audience what is glaucoma? Let's start with that.
Well, glaucoma is a disease that increases the pressure in the eye, and it affects the optic nerve in the back of the eye. When the optic nerve is affected in the back of the eye, your peripheral vision starts to shrink. So that's why we call it the sneaky thief of sight, because we're all looking straight ahead, okay? And we don't really notice so much that the periphery is decreasing, partly because we have two eyes, and so one eye will compensate for the other. So you can have like end stage pinhole vision, straight ahead without knowing that your peripheral vision was decreased.
Hmm. And what causes glaucoma?
Again, genetics. I'd say 2% of the general population does have glaucoma. It's increased in Afro American uh, people, and also family history. If you have a family history, that 2% goes up to about 20%.
Oh,
And
really?
it's really a plumbing problem where there's either too much fluid produced into the eye and the pressure goes up, or there's too little outflow down the drain, letting the pressure, you know, um, build up. Also,
Like,
steroids use could sometimes increase the pressure.
Gotcha. So how do you monitor the pressure in a patient's eye? A patient comes in, gets an eye exam. What do you typically do? I know you check the pressure. Uh, what do you typically do to keep the pressure in line, so to
Oh,
speak?
yeah, part of that routine exam, we check pressures on everybody called the tonometer. Normal pressure is between about 10 and 21, but if you have glaucoma in a bad way, you probably want that pressure to be under 15, even closer to 10. Um, so yeah, we measure that in the office, and we look at the optic nerve, we look at the corneal thickness, and we check the pressure, maybe a little family history, and we make a determination as to whether the patient needs more detailed investigation about glaucoma, such as visual field testing, which tests that side vision, or or a computerized image of the back of the eye to look at it. It's called an OCT to look at the nerve fiber layers. So we do those, and we also measure corneal thickness.
Gotcha. So how do we treat it? You've made you've done the testing, you've made the diagnosis that, hey, this ugly, nasty disease is here. How do we treat it?
Well, there's two ways to treat it in the beginning. One is drops, and the other is laser in the office. So I'll discuss the laser first. The laser is called an SLT, selective laser treatment, and we bring the patient into the laser room and we aim the beam at that drainage canal, anywhere between 180 or 360 degrees of laser, and that will typically get the pressure down about 3 to 5 points, and it usually lasts for about a year and a half to 2 years, and you could repeat it if it was successful the first time. So that's certainly one way to do it for people that don't want to deal with drops or the side
Mm-hmm.
effects of drops or the cost of drops.
Mm-hmm.
In fact, it's been shown in studies that that should be the first line of treatment, but a lot of patients are a little, they'd rather do drops, so we start drops. The drops fall into a few categories. One is the prostaglandin inhibitors, which have no effects on the body, actually, other than some red eye sometimes, and that increases the drainage canal. Then there's the beta blockers, which decrease the pressure in the eye by decreasing the amount of fluid in the eye. However, a beta blocker could affect the heart and lungs,
I
could
see.
affect with asthma, could affect, make your heart rate go slower. So it's up to the ophthalmologist to make sure that the patient doesn't have, cardiac or pulmonary diseases, or if they do, it's just a little slight amount. And then if you see the patient back in a week or two, or you tell them ahead of time, hey, if your pulse goes down or your breathing
Mhm.
is worse, let's get off those drops.
Sure.
So those are the kind of the two categories. There's also a Diamox type of pill, which is a diuretic, which decreases the pressure in the eye, and the Rocklatan drop, which is a combination, which also decreases pressure. There's about four categories of drops that you can use. Typically, a patient might be on two, I'd say maximum of three, before you want to do a laser treatment or surgery.
Understood. Understood. And what percentage of the patients, or does it just vary that you have to get to the surgical stage? Do you find the majority of patients reacting to the drops well, or do you find that X percentage you have to go to surgical procedure?
Yeah, I'd say the vast majority, probably, I'd say maybe 90% in a general ophthalmology practice like mine versus a glaucoma specialist.
Mhm.
Glaucoma specialist can have more of the end stage stuff,
Mhm.
but I'd say 90% of my patients could be controlled with laser treatment or drops. You can do both, actually.
Gotcha.
Um, at the time of cataract surgery, we do frequently do or off the patient to do a MIGS procedure, which is a micro-invasive glaucoma procedure, which doesn't make a filter or anything invasive into the eye, but rather we can aim at the ciliary body with a laser to decrease the production of fluid, or we could put these micro stents called eye stents to put in the drainage canal to make it drain better. So yeah, whenever I see a patient on a drop and or their pressure is not very well controlled, I will tell them at the time of cataract surgery, I would recommend doing this microinvasive MIGS procedure. Only takes about another 5 minutes, and it
Understood.
frequently will decrease the pressure by 2 or 3 additional points. And then if the pressure is much too high, then you need some sort of filtering or tube procedure to actually drain the pressure down more.
Got you. Now, the damage that's caused until you so-called put the brakes on it with the drops or surgery or any of the treatments that you just mentioned, is the damage reversible, or are we just trying to stop it from getting more damaged?
Yeah, it's irreversible damage. Unfortunately, it's a nerve, and we don't really know how to regenerate nerves, at least clinically. I think in the laboratory they're working on it, but we can't regenerate an eye nerve to make it better. So, like you said, we're putting the brakes on to keep the patient from crashing.
Gotcha. 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 Well, that's very interesting. I'm sure that a lot of folks out there will certainly learn a lot from about glaucoma just from the words that you just mentioned. But I just want to move on to the retina. We're running a little short on time, so I'm going to move on to the retina. What is the retina?
Well, the retina is like the film in the back of the camera. It absorbs all the input, into the eye, and then it sends it to the optic nerve, and it sends that to the brain. So the retina, it gets nourished with blood vessels, both veins and arteries, and different diseases could affect the retina as well.
I see. And what are the examples of some of the diseases or symptoms that gives you the alert that, hey, something's going on with the retina? I know flashes and floaters might be one. You want to talk to us a little bit about that?
Sure. Yeah, if you have flashes and floaters, you should call your doctor, and they should hopefully see you the same day, or if not, the next day. If you have a curtain coming down, you should definitely be seen the same day, because that could be indicative of retinal detachment. Now, 50% of people over 50 have a simple floater that's annoying, but it's not a retinal detachment, but that has to be looked at. So I'd say about 95% of floaters are just annoying nuisance floaters. 5% of those floaters could indicate you have a tear in the retina and or a retinal detachment happening.
Gotcha. So just for the folks that don't know, what exactly is a floater?
A floater is a particle that's appearing in the vitreous jelly of the eye. And again, it could be this benign type of floater just from the vitreous jelly shrinking, or it could be a floater coming from a tear on the retina. And you
Eh,
see this little thing moving around in your vision that you didn't see before.
Gotcha. That's what I was trying to get at. What would the patient see and say, hey, that's a floater? It's just that little
Yeah, little
annoying thing that,
spots, little flies. It's like, oh, I'm swatting flies, but they're
right.
not
And
there.
I understand. And Monacola, well, let's just say this. Why don't you go through instead of me going through my list in the interest of time, why don't you tell us exactly what you think the audience our audience should know about the retina, how to keep our retina healthy, how often to get it checked, and what are the warning signs that we should look for? Just in summary.
Yeah, well, the two biggest things your audience should know about the retina are really diabetic retinopathy. Anyone that has diabetes should watch your videos and stay in shape. You got to stay in shape and eat the right things to keep your blood sugar in shape, in good point. If your blood sugar is high, it could lead to diabetic retinopathy in the back of the eye, because there could be a leakage of blood and or proteins in the back of the eye. If that's a small amount, it could be observed. If it's a larger amount that's affecting the vision, then the retina doctor or a good general ophthalmologist will have to do some injections in the eye and or laser treatment to prevent that from getting worse.
Mhm.
You could get edema or fluid and your vision could get worse. So that's diabetes in a nutshell. macular degeneration, that's also hereditary, like we said with the, well, so is diabetes also, like we said with glaucoma. If a person's family has macular degeneration, there's probably about 10% chance that they will get it. And that's I'll say it's not really silent because that affects the central vision. Glaucoma affects the side vision.
Mm-hmm.
Macular degeneration affects the central vision.
Central
In the
vision.
beginning, you can get some distortion. So it's the eye doctor's job on the routine exams, and everybody over 60 should get an exam every year. Under 60 should be probably every 2 or 3 years. Diabetics should get them at least once a year. And the doctor on their routine exam will look for these little particles in the back of the eye called drusen. And drusen are a risk factor for getting dry macular degeneration, which could be observed, or they can get wet macular degeneration. That's the dangerous one. That's the one where there's new abnormal blood vessels that are built in the back of the eye and they bleed. And when they
Mm-hmm.
bleed, they will decrease the vision. And again, there's VEGF. They call them VEGF injections, Avastin, Lucentins. Those are some of the most common ones that the retina doctor will do for you, and those get injected about every 6 to 8 weeks.
Gotcha. So to diabetics, it's very important that you share with your eye doctor that you are a diabetic. Would you
Right.
say that that's something that everyone should do if you're a diabetic?
Oh yeah, and for sure. And your PCP, your medical doctor, will insist that you see the eye doctor once a year, so that your diabetic retinopathy, if there is any, is caught at an early state that's treatable.
Gotcha. And dry eye. Uh,
Your dry eye is another nuisance thing. It comes from the lids, actually. The lids have meibomian glands in them, little
mhm,
oil glands, and those
mhm,
tend to dry up a little bit when we get older. I love to recommend for myself and all my patients a heating pad, actually, at night. You put this little heating pad in the microwave, specifically for the eye. It looks like the eyeglass, size of an
mhm.
eyeglass. Put it in the microwave for about 20 seconds. You lay it on your lids for about 10 minutes, makes the oil glands work better. That's really getting at the root of the problem for the most part. Putting teardrops in also will help. And then there's medicated eye drops. One of the most famous is Restasis, and then other ones that have come along that are similar to Restasis as well, that could help the consistency of the tear film as well.
I see. And how do you diagnose dry eye? Is it just on a regular eye exam? Is that the way you diagnose it?
Yeah, a lot of it is the symptoms that the patient has. Paradoxically, the patient could say it feels dry, scratchy, itchy, or they could say it's teary. So why would a dry eye be teary? Well, it's teary because there's actually three components to the tear film. The most important is the oils. So if you don't have the oils, you're going to get evaporation, and the body is going to secrete these very watery tears called aqueous. And the
Mhm.
aqueous tears will be very uncomfortable, kind of tear down your cheek and stuff like that. They're not really helping the eye, but it's a reflex that the body has if they don't have enough of the oily stuff. So it's symptoms as well as what the doctor will see on a routine exam, where they put a yellow drop in the eye to both test the pressure, and they look for any staining or dry eye spots on the cornea. And if the doctor sees it, they should proactively ask the patient to do some treatment.
Gotcha, gotcha. Thank you for that information. And finally, pediatric eye care. Many of us, many people that are watching have children, grandchildren, and so talk to us a little bit about what should we do? How often should we have the kids come in for an eye exam? Just in general, just give us an overview on pediatric eye care. What are the things that parents and grandparents should be doing?
Well, certainly, once the child gets to about, a month or two, you should make sure the eyes are aligned, that they're both looking straight ahead.
Mhm.
If they're not, you got to talk to the pediatrician and have that pediatrician refer to an ophthalmologist. Also, if there's any white reflex in the eye, God forbid there's a white reflex, that could be a tumor in the eye. So if one of the pupils look white, you got to really get that done right away.
Mhm.
Um, as time goes on and the child is able to verbalize things, you can bring them to the optometrist or the ophthalmologist, probably at about 2.5 or 3 years old, or in the pediatric office, and have them read things in the front. Now they're not going to read their ABCs at that point, but they could identify figures, a bird or hippopotamus or whatever. So you can have them identify those things, to see if they're seeing 20/20 or not. Also, the auto refractors and other refractors you could use, you could determine if a patient may be very nearsighted, very farsighted, or have a lot of astigmatism, in which case they should get glasses at an early age so they get focus. You can get a lazy eye where one eye, the vision isn't developing very well. And the way to solve that is either with patching, or you put drops in the other eye, the good eye. You should put drops in the good eye so that the bad eye will get better. The brain will depend on that. And you
Yeah.
got to do that by like 11 years old, or else the brain won't really be plastic enough to adapt to make the vision better. So some kids will need glasses, some kids will need the patching. If the eyes really turn, they'll need prisms in their glasses, or they'll need eye surgery for that as well. You also want to see if there's a lot of tearing in the eye. If there's a lot of tearing, they may have an obstruction of the tear duct. So those are kind of the main things with with children you got to look out for, I would say.
Gotcha. So we can't just assume just because they're children, they're young, vibrant, that, oh, eye problems won't occur. So we should keep an eye out for certain things.
Yeah, yeah. If both eyes are straight and one's lazy, that could be. You may not know that, until they get the eye exams.
Understood. Well, Dr. Solinsky, we want to thank you so much for taking the time out of your busy schedule to join us tonight. I know that I've learned a lot, and I know that the audience that will see this podcast will learn a lot. And we want you to keep up the good work. And we don't want you to ever retire.
Okay.
We want you to keep doing the good work. So
You
thank you
too.
for joining us.
Yeah, you too. Yeah, thanks a lot. You're doing great service for everybody, Paul. You
Okay,
keep it up.
thank you, and God bless you. And come back and join us anytime you want.
Yeah, I'll be there anytime you call me back.
All right, God bless you.
Yeah, you too.
Thank you, Dr. Alan Solinsky. That was very informative. Thank you for joining us again, taking the time out of your busy schedule to share your wealth of knowledge with us, our audience. We really thank you, and we know that you're committed to the community, staying in good eye care, good eye health, and we thank you so much for joining us. And I know that, as always, we see that exercise ties into eye care. Exercise ties into a lot of health issues, and if you exercise, you have good outcomes with your health. And as we see, obviously, diabetics are exposed to certain eye issues, and we all know that exercise can really help with diabetes and the blood sugar level, and as we see, it ties into eye care. So I just wanted to thank Dr. Alan Solinsky again, and all the folks at Solinsky Eye Care for sharing Dr. Solinsky with us, taking his time to give us the information that we need to hopefully keep us in good health. And I just want to, again, encourage everyone, as I always do, to exercise. It's going to help you to have good outcomes in life, help us all to have good outcomes in life. So keep up the exercise, and you'll see me in the park continuously. Stay tuned for our next podcast episode on Get Fit, Stay Fit, Never Too Late. You'll get a wealth of information, and we all know that knowledge is power. So thank you and God bless you.